Hello and good afternoon and good evening. Thank you for attending this lightning talk. My name is Sultan Babar. I am a consultant physician and a clinical informaticist in the Department of Emergency Medicine at King Faisal Specialist Hospital and Research Center located in Riyadh, Saudi Arabia. Today, I will be presenting on our computable antibiogram prediction system, which we call CAPS for short. Before I get too much into caps, let me just sort of highlight the background of it. Probably almost every single hospital in the world publishes, paper antibiograms. Now, these are generally a list of susceptibilities for each organism that grows out of, urine or blood. In our example, we will focus on urine because that's where we are applying this right now. Now it gives us, which organisms are growing out of the urine and also what they are susceptible to antibiotic wise. Usually they're either published in paper format, emailed as PDFs or spreadsheets. They're almost rarely consulted at bedside, and which leads to the information being there but not being easily usable. And on top of that, frequently the organism, for example, in urine, is not known at the point of care. We know that the patient likely has a urinary tract infection, but we are uncertain of what that organism is going to be. Now, so we came up with the CAP system. Now, what that does is there's two layers to that. The first layer is that it takes in the patient inputs, age, sex, urine dip, and a few other characteristics, and it comes up with what we call the prediction layer. It's a machine learning model that we trained that takes all these layers and gives us the probability of the culture being positive and what those likely organisms are likely to be. And the second layer, what it does is it takes the antibiogram data that we insert in a JSON format and calculates what we call the coverage score for every antibiotic, which is the probability of that probability of that organism and the susceptibility of that organism to that antibiotic and sum of all those for each of those organisms. And then finally, the physician is given a ranked list of the antibiotics that it's more likely to be susceptible to. Here's an example of that. For example, if the predicted organisms in this urine cultures are likely to be E. coli, 70%, Klebsiella 20, Proteus 10, with these susceptibilities to nitrofurantoin. Then obviously a product of those and then some of those products will give us 79.5% probability score, which is then ranked along with other antibiotics and presented to the physicians. The benefits of this is going to be is that one, if it is in a computable format, the CDS can use that and give the physicians the ranked choice list. The paper antibiogram is obviously unable to do that. The other advantage that we have with the computable pathway is that once the new antibiograms are published, there's a steep adoption curve, and some physicians may not even change their habits or prescribing patterns if there was a significant shift in the antibiogram, and to get them to change it requires significant effort. But if CDS is what's giving them the ranked choice list, then as soon as we replace the computable antibiogram, the new ranked list would automatically take into account the new antibiogram. With that, any questions?